This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this video is a tutorial on how to approach case of a PC tear in a step-by-step manner. The scenario now is that we have a posterior capsule tear. We're not sure whether vitreous is prolapsed out. We are having a lot of lens matter still in the capsule bag. Maybe epinucleus and a very large sheet of cortex. Now, how are we going to address each of these issues? When do we start doing vitrectomy? When do we start doing cortex aspiration? And these are some of the points which I'm going to discuss through this video. A young trainee surgeon is operating, and after the last piece of emulsification, he's suspecting a posterior capsule tear, looking at this red hole-like thing in the posterior capsule. And at this stage, he's not sure about the extent of the posterior capsule tear. He's just suspicious of it, simply because there is an overlying sheet of thick cortex and probably an epinucleus. And the only thing which is convincing him is that when he puts in the OBD, the size of the circular tear doesn't seem to enlarge, suggesting that maybe the vitreous prolapse has not yet occurred. And he calls for help, and this is a situation where I'm looking at the case now. So at this stage, now how do we diagnose the presence of any vitreous? Now, because the circular shape of the tear is still maintained, and putting in triamcinolone acetate at this stage might not give us a very good idea, simply because the OVD would have pushed back any prolapsed vitreous and it wouldn't stain it. So I thought maybe I'll just go in and first try to do some cortical aspiration, and then if there is evidence of any prolapsed vitreous, then definitely I'll start doing the antivitrectomy. So the first take-home message here is, if we are sure of a vitreous prolapse, then vitrectomy has to be done first and not cortical aspiration. In this case, I still believe that the vitreous is not yet prolapsed out, so I'm now trying out to remove the cortex first. The bottle height is reduced a little bit, the aspiration and flow rate parameters are decreased, and then I proceed to aspirate the thick cortical sheet. As I'm attempting to remove this thick sheet of cortex, I can clearly see some lens debris floating around behind the posterior capsule in the antivitreous. As the last piece of cortex is being aspirated out, well, I can see that a vitreous fibril has got entangled into the aspiration port. I need to stop immediately, and this is a clear-cut indication that the vitreous disturbance is now present. I need to come out and start doing the vitrectomy. At this point, I can also note a small nuclear fragment is hovering just below the posterior capsule tear. So I'm just going to use the viscoelastic to nudge it more anteriorly. I'm pushing OVD behind it. Now, how do we deal with this small fragment? So I'm just going in with my vitrectomy cutter itself. The chamber is maintained by OVD, and with the cutter I'm going to just go cut some of the vitreous which is around it, and then probably burp this fragment out of the incision. Time to perform the antivitrectomy. Let me pause here and let me just show you the orientation of the vitrectomy probe. So I prefer to keep the probe facing posteriorly, and I begin to do the vitrectomy. The vitrector is placed at a level posterior to the posterior capsule tear. So the idea is cut the vitreous below the level of the posterior capsule tear around, and the anteriorly prolapsed vitreous will be dealt with later on. The idea is to cut all the connections between the vitreous body, which is posterior, to the anteriorly prolapsed vitreous. By doing so, we can prevent the enlargement of the posterior capsule tear during antivitrectomy. Now the port of the vitrector is turned sideways and then anteriorly to cut and aspirate the vitreous which is in front of it. Now I can see that the posterior capsule tear edge is fluttering very freely. Now this is a sign which indicates that there is no vitreous around the posterior capsule tear. If there is vitreous around the posterior capsule tear, it wouldn't flutter because the heavy vitreous would tug at it and prevent the flap from fluttering. So when you see a free fluttering posterior capsule tear, it is an indirect evidence that there is no vitreous near its vicinity. Whereas in the subincisional area, I'm still not very sure that it's totally free of vitreous, because looking at the configuration of this cortex suggests that there could be one fiber which is traversing across towards the main incision. There's a reason why it may not be happening. In the meanwhile, there is a small fragment which has floated up and moving around in the antechamber. Just go in with my cutter through the main incision, press the posterior lip so that it just flows out. And this is one small trick which can be helpful. Now, once I'm sure that there's no vitreous in the vicinity of the capsular bag, now is the time to deal with the cortex. So the first lesson, when vitreous prolapse is there, stop everything, deal with the vitreous, and then proceed to remove the cortex. The fragment which I thought had gone out is still hiding inside, and this is not coming out. I just don't want this small fragment to drop down. So before I do vitrectomy, I just want to burp this out, and then I'm going to switch hands and try to remove the cortex from the other side. Again, in this area, the cortex can be aspirated very well, very easily, and once the cortex is cleared off in that region, the lateral limit of the posterior capsular tear can now be visualized. At this point, I'm thinking maybe I have an opportunity to do a posterior capsular rhexis now. Time to remove the last bit of cortex in the subincisional area. So at this point, as I'm trying to remove the cortex, I can see there is probably one vitreous fibril which is getting entangled, and I need to deal with it. So it would not be wise to again go ahead and proceed with the cortex aspiration. The irrigation is still on inside the eye. I exchange my irrigation handpiece with an vitrectomy cutter, and I need to deal with the prolapsed vitreous first before dealing with this cortex. One trick when you're trying to remove one single vitreous fibril is to change the setting from cut aspiration to aspirate and cut, so that you go in with the IA cut mode. When you go to foot pedal 2 position, you start the vacuum, which just goes and tucks at the vitreous fibril, and then you cut with your cutter. So that is one way of dealing with the single fibers. For doing the regular vitrectomy, always the cut IA is the mode to go. Again, in such cases, I think you need to be mentally prepared for a long haul. So it would take multiple entries to deal with one vitreous fibril, but it is worthwhile. Now, once the vitreous is cleared off, the remaining cortex is aspirated. Again, there seems to be a small fibril there. Now, before putting in the lens, I just want to go ahead and take care of this one prolapsed vitreous fibril one more time. Finally, I think this single vitreous fibril is dealt with. Now is the time to implant the lens. Space is created in the sulcus by placing OVD under the iris and above the anterior capsule. I'm going to use the blade to enlarge the incision just a bit. Remember, when you do antivitrectomy, the eye would be soft, and it would be difficult to negotiate the cartridge through a regular size incision. A larger incision does make the job much more simple and effective. Okay, time to implant the lens. In this case, I'm using a new lens which I am not very well accustomed to. This is the Aurolab multi-piece hydrophobic lens. So as I'm implanting the lens, the haptic goes in alright, but the lens flips. So now it is in an orientation which is the other way around. It's flipped. So how do we straighten it? So it is difficult to flip it with a single instrument. I prefer to use 2 Synskukes from either side ports, and this would help me to maneuver the lens or flip it back to its recommended orientation, that is the inverted S. The trailing haptic is then dialed into the sulcus, and now we have a multi-piece lens in the sulcus. Before we achieve optic capture, I would like to go ahead and remove all the OVD which is gone behind the lens and into the vitreous cavity. The irrigation is in my left hand, the cutter goes in through the right hand side port under the lens, and then in a couple of minutes the OVD which has been pumped into the vitreous cavity is all cleared off, along with some of the lens debris as well. The haptics are oriented in such a way that I'm avoiding the longer axis of the rhexis because it is not central and it's not circular. With the haptics now being in an appropriate position, the optic is pushed back to achieve the optic capture. The ovalization of the rhexis suggests that. I'm going to use the Synskuk just to confirm that the anterior capsule is above the optic, and this is how it is done. Now before closing, I'd like to confirm the presence of any prolapsed vitreous fibril by using a diluted triamcinolone acetate, and thankfully it is none. The intracameral pilocarpine is used to constrict the pupil. So time to close. Now, in an event of a PC tear and antivitrectomy, it is always recommended to go ahead and suture the wound, especially when the eye is hypotenuse. Now, in this case, once I do hydrostitching, the wound looks to be quite stable and the eye is firm, there is no hypotony. So in this particular case, I have opted out of putting any suture. The intracameral antibiotics are placed, that's it, the case is done. Now, these are the post-op pictures on the 10th day, and this is the undilated view, and this is a picture with a dilated pupil. After dilatation, the intraocular lens looks a bit decentered, but the lens is not decentered. It's actually the rhexis which is decentered, and the optic is captured in this decentered rhexis. That's the reason why it appears as slightly decentered. But achieving a optic capture is critical as it ensures long-term stability in a better way. And the patient is being monitored. After maybe 2 weeks, 1 month and 6 weeks, we're going to evaluate the peripheral retina for any presence of any retinal break, and also the OCT macula needs to be done to rule out any CME. To summarize, a few key points. When we have a posterior capsular tear and question mark vitreous prolapse, first a certain vitreous prolapse. If there is vitreous prolapse, always proceed with the antivitrectomy first before thinking of removing any other cortex. Because if you attempt to remove cortex and if there is a prolapse vitreous, we're going to cause traction at the vitreous base, and that can induce a retinal tear. That is much more difficult to treat. So always first perform vitrectomy and then do a cortex aspiration. So whenever during cortex aspiration, when we have a doubt that the vitreous is prolapsed again, it is required for us to stop the aspiration of the cortex, deal with the prolapsed vitreous, and then proceed with irrigation aspiration. And finally, multi-piece lens has to be kept handy for every scenario, and it's going to be a lifesaver in such situations. Thank you for watching and hope you found this helpful.